It is a pleasure to be with you all here. I recognize that some are still grabbing their box lunches and walking in. Please take your time. We are thrilled to have you join us. My name is Ramez Iskander, and I'm going to serve as a moderator for this afternoon symposium. The title for today's symposium is The Long Game in Endometrial Cancer, Interpreting Progression-Free Survival, Overall Survival, and the Power of Biomarkers. IGCS would like to thank GSK for their support of this symposium. I would like to get us started. In an effort to stay on time, I will have each of my colleagues, Dr. Coleman, if you can introduce yourself first, and then Dr. Pathuri. Yes?
Yeah.
I'm going to review the objectives really quickly, and then we'll get going.
All right, I'm going to stand by you so
Please
we can get through them
stand
quickly.
by. I've told
I'm
you.
Rob Coleman, GYN oncologist in Texas.
Dr.
Bhavna?
Pathuri.
Bhavna Pathuri, GYN oncologist at NYU Langone.
Wonderful. So we have a few objectives in this afternoon session. We're going to evaluate and compare recent clinical trial designs and key efficacy outcomes in endometrial cancer. And we're going to focus on how the methodology and the conduct of the clinical trials can influence our interpretation of the data, particularly in the mismatch repair deficient population. We're going to talk about how to interpret the results of these phase 3 clinical trials and the implications, and to a certain degree and in more granularity than we did in the session prior, talk about this idea of developing biomarkers to inform treatment decisions in the mismatch repair proficient cohort, such as HRD signatures, P53 status, PD-L1, etc. We're going to talk about the implications of examining subgroup analysis to inform treatment decisions and regulatory approvals, and current gaps and unmet needs in the management of endometrial cancer. And lastly, we are going to try to keep this as pragmatic as possible, and Dr. Pathuri is going to help us apply this clinical trial data and learning opportunities using key patient cases that are reflective of the individuals that we are fortunate enough to care for in clinical practice. The learning objectives are also listed here for your reference, and on the next slide, the agenda is shown for the symposium today. So, without further ado, Dr. Coleman, please take us through clinical trial design in the DMMR population.
Thank you, Ramez.
Good job.
Yeah, thanks everybody. Ramez was going through the objectives, and I hope you got a chance to listen to, because we're taking a little bit of a different tack on just reviewing data. What we're going to do is we're going to talk about, I'm going to start us off by talking about the biomarker itself and how that's been implemented successfully in trials that have now led to this in many places around the world, the indication for immune checkpoint inhibitor therapy in the frontline setting for DMMR tumors. But also wanted to share a little bit about how these trials were constructed and why they're practice changing. So that gives us a good opportunity. So I'll start with the end game, the end point here. You know, in many places around the world, chemotherapy plus immunotherapy followed by an immunotherapy maintenance strategy has been approved for biomarker unrestricted. In the United States, durvalumab is approved for the DMMR cohort, but you can see that pembrolizumab and dostarlimab are also indicated for the DMMR cohort, which is really the focus of what I'm going to be talking about. So how did we get there? Well, there was a lot of work that went behind the scenes. So not only was there a bunch of hypothesis-generating activities that came from our understanding of molecular characterization, and this today you've heard a lot about this already, so it's been very, very exciting to see the fruits of that labor. But then we also went through a series of very important considerations with respect to the eligibility of the patient population, the statistical design of the population, of the trial, and then how those endpoints were leveraged and how they have ultimately demonstrated benefit and what we classify as benefit. And then I'm going to finish up a little bit about the investigational strategy, because we do these trials, if we're going to put the effort into doing a phase 3 trial, asking a specific question, it doesn't really help us to do it just to do it. We want to do it because we want to make sure that we can bring it to the clinic. And that's ultimately going to be the investigational strategy and the unmet medical need. Now, with respect to this idea of investigational strategy, and I'll come back to this at the end, has to do with what the regulatory environment is in your individual environment. So I'm going to talk about the U.S. strategy because this offers a couple of different opportunities for us. there's two playbooks that we've operated under for these kinds of trials. One of them involves this idea of dose optimization. We talked a little bit about this in the last session. And then we would expand, once we've had the right dose, for an accelerated approval opportunity, which is unique for the US and in some additional areas around the world. But it allows that to enter into essentially an availability under an accelerated approval pending the confirmation of a trial that is larger and evaluated usually in a randomized fashion. And the filing for that accelerated approval, for that approval in the United States, will come after the confirmatory trial is what we call substantially enrolled. And this is really important because it allows the FDA confidence that what they're making a decision on relatively limited data for accelerated approval to confirm it and then ultimately get a filing for regulatory approval. The other playbook opportunity is to do the dose optimization and then start the registration trial right away. But in the process of enrolling patients, one of the arms of the trial would be used to identify a potential accelerated approval opportunity while the trial is ongoing. And then once those data are formalized, they can file for accelerated approval while the registration trial is going on. And both of these strategies provide an opportunity to bring compounds to the clinic earlier than waiting for the final approval. And this has been very successful and obviously a focus of a lot of drug development in the United States and other parts of the world. So as Ram has mentioned, we're going to focus on the DMR population. And of course, molecular characterization is really what's driving this the progress that we've been making in recent years. We know a lot about this DMMR subpopulation, and we've interrogated it multiple different ways. But the first signal that there was something different about this population came from the TCGA more than 12 years ago. And what we learned about this subpopulation is that when we looked in the tumor microenvironment, there was a number of characteristic changes that would align with an immune checkpoint inhibitor. Number one, we started to see tumor-infiltrating lymphocytes, and the character of those tumor-infiltrating lymphocytes were CD3, CD8. We also know that there is some relationship, although this may not be a biomarker in endometrial cancer, that PD-L1 expression is also related to this DMMR status. And you can see how these particular endpoints are different from microsatellite stable to microsatellite insufficient to the POL-E classification. So this provided pretty strong evidence that there were tumor cells in the microenvironment and that they were something that we could identify as a cohort of patients ahead of time and align with an immune therapeutic strategy. So we did just that. So after this preclinical work, we then started to look at whether or not a single agent could actually shrink tumors. And so we saw a number of these phase 2 single-arm experiences with immune checkpoint inhibitors that showed not only that they could shrink tumors, but they did so at a different rate that aligned with the biomarker. So you can see over here the MMRP category versus the MMRD category, that the response rates are vastly different, which aligns with the hypothesis. So what I'm trying to explain is that we have built a preclinical hypothesis. We're bringing it into the clinic to testing the waters to see if that's actually true. And then we ultimately want to validate it in a phase 3 setting, which we did with these 4 trials. And I'm going to go through these very quickly. They're going to be discussed in detail with my cohorts here. But I wanted to highlight just that in the PFS arm, where you can see where DMMR is highlighted in red. And this particular table also identifies all of the endpoints that are, quote, analytical. And I'll make reference to that as we go forward. But you can see that of the 3 trials that had DMMR as an analytical endpoint, they were all positive and wildly positive. Hazard ratios around 0.3, representing a 70% reduction in the probability of an event of progression. And if you remember looking at those curves that were presented earlier today, if you go out at 3, 4, and 5 years, you can see that if a patient made it 3 years without progression, the likelihood that they would progress at 5 years is almost 0. So we are curing some of these patients with this particular strategy. So the successful design strategy, as I mentioned, is really important as this goes forward, and a lot of thought goes into these trials as they go forward. And I've listed out these elements as before, but I'm going to focus now on biomarker enrichment and coming up with a homogeneous population. So central to this idea in the DMMR cohort was that we figured out that within this molecular classifier, within the molecular classifiers, that these particular biomarkers serve more than one function. It's always nice to have a prognostic biomarker that helps us to inform patients on what expectations are. But as we're leveraging new therapy, it's really the predictive biomarkers that actually can drive change. So both of these particular characteristics of a biomarker are important, especially in clinical trial design when it comes to stratification variables. But when we talk about it from the standpoint of using a biomarker to direct therapy in an integral way, the therapeutic potential for them becomes relatively critical. And so the question we have to ask is, can we find it? And of course, we know that with endometrial biopsy that we can assess for these biomarkers and identify the patient population that would be most likely to benefit from from immune checkpoint inhibitor. And so I'll use GY018 and Ruby as just example test cases through this example, just only to highlight how DMMR was evaluated within these trials and led to their regulatory approval. You guys are should be very familiar with these two studies. They've been available in the public domain for some time now, and we've talked about them many times. But to just put these together with respect to the inclusion criteria, you can see that these two trials shared a number of features, such as measurable disease, non-measurable stage 4, patients that have recurrent disease that were included, and that good performance status. But they also differed on some characteristics. And you can see that the non-measurable carcinosarcoma and clear cells and serous tumors were part of Ruby, but not part of GY018. And patients with poorer performance status, PS2s, were included in GY018, but not in Ruby. And then again, this idea of completion of time from the finishing their adjuvant chemotherapy was different, greater than 12 months and greater than 6 months. And those were differences that were identified. Nevertheless, overall in these two trials, you can see that the fraction of patients that carried the biomarker was around 25 to 30%, so 28.4% and 28% respectively between the two trials. And you can see the sample sizes of these trials are slightly different. Now, the next key piece of this, after we've gone through the eligibility, is to look at how these particular populations were analyzed. Did we design this trial appropriately for size, power, and optimal stratification? And I'll talk a little bit about informative censoring because this becomes a real major problem in trials that are not blinded or when there's the availability of the alternate arms outside of the clinical trial context. So just for review, because I know you have to do this whenever you talk about stats, we have our null hypothesis, and again, for a superiority trial, which these two were, what we're trying to do is reject the null hypothesis that there's no difference between these arms. And then we do that with confidence, and our alpha allocation is our probability of incorrectly rejecting the null hypothesis. So we say, oh, we've rejected the whole null hypothesis, but actually it's true. So we set that arbitrarily, or by clinical convention, I would say, at 5%, or about 1 in 20 times we would get it wrong. That's what alpha allocates. Beta is a form of confidence against that decision. And so technically, beta is the probability of incorrectly accepting the null hypothesis. We usually allow a little more leeway for this, about 10 to 20%, so it's about 1 to 10 to 1 in 5. And the power is essentially the 1 minus that particular number, which again is the confidence for rejecting the null hypothesis. So with that standpoint, we design our trials, and then we try to allocate these particular variables to the analytics, which I'll describe in a second here. But we also want to design the trial to control for important prognostic factors because we don't want differential effects that are just purely based on the prognostic implications of those variables to not be balanced. It's okay to have a heterogeneous group of patients, but what we want to do is to make sure that if there are prognostic factors that are included in the eligibility, that they're balanced between the arms of the randomization. And so if you put Ruby and GY01 up next to each other, you can see that they shared MMR status as a prognostic stratification, and 1-to-1 randomization was done. But you can see that ECOG status and prior adjuvant chemotherapy, yes, no, was a stratification variable for GY018, whereas for Ruby, it was prior pelvic radiation and disease status, whether it was recurrent or primary, stage 3 or primary stage 4. Now, these might be important because if you remember, what was the difference between the treatment-free interval that was allowable between these two trials? So it was less than 6 months, or 6 months or more for Ruby, and 12 months or more for GY018. So there may be this idea that the interaction of that effect, of the platinum-free interval, if you will, might have less of an importance on the outcome of these other variables if it's longer or shorter. That's the kind of decision that has to go in to try to understand how we would design a trial with respect to these stratification factors. So with respect to the statistical design, you can see that GY018 took the one-sided alpha of 2.5%, so this is like 0.05 split equally. It was split equally between the pMMR cohort and the DMR cohort. Essentially, these two trials run in parallel, essentially as two separate studies that are defined by the biomarker. So, and it split the alpha in each of the cohorts equally. It only split it to PFS. And you can see those are the analytical endpoints. For Ruby, it was more done in the hierarchical standpoint where the one-sided alpha was split mostly on PFS, but it preserved some of the initial alpha for OS. This was done to safeguard the opportunity where we saw no PFS effect, but then we're allowed to look for OS as a late effect of immunotherapy. So there was two different strategies here that were applied to these two studies, and both of them had interim evaluations for these endpoints. So with respect to what happened when the trial was conducted was that both GY018's arms, the dMMR cohort and the pMMR cohort, demonstrated significance at above these thresholds or below these thresholds to demonstrate statistical significance in an analytical way for the pMMR and the DMR cohorts independently based on that alpha allocation. Whereas in Ruby, you can see that PFS was set at 2%, OS 0.5%, and then you can see that the hierarchical program was to initially evaluate the dMMR cohort, and if it passed, then it would pass that alpha to the ITT population, which would include the pMMR cohort. So the dMMR and the pMMR done sequentially. And if those were positive, the alpha was then passed to the intent to treat population, so globally, for overall survival. And you can see that there's a P for boundary of 0.00177, which I'll talk about in just a second, as an interim cut point for overall survival. Now, the primary endpoints of these trials, as I just mentioned, were different. Both of them included PFS by RECIST as an investigator assessment. But in the MMRP and DMMR cohorts, they were independent in GY018, and they were sequential or hierarchical in Ruby, whereas overall survival in the ITT population was an analytical endpoint. Now, this idea of frequency of imaging becomes important. If you can imagine that if you evaluate patients, let's say once every 6 months with CAT scans, what will happen in that 6-month window is that some of these patients will present with symptoms, or they'll present with overt findings on exam, which will then cause you to do off-cycle imaging, and that potentially could end up as an event. On the other hand, if you were to do imaging every week, you would be able to very precisely identify when progression happened, whether the patients were symptomatic or not. So between these two kind of extremes is somewhere where it's acceptable frequency of imaging, but it's not too far or too narrow to be able to provide some precision on the event of a progression. And and you can see these were slightly different between the two trials. And then the last kind of category is this maturity idea, interim assessments, the regulatory interaction, and as I mentioned, the investigational strategy. So I just shared with you how GY018 met its two primary endpoints for progression-free survival. Now, overall survival wasn't an analytical endpoint. We have some early evaluation of overall survival in a paper that Ram has published in Nature Medicine earlier this year. But in Ruby, that it didn't meet that interim threshold, so we waited for further maturity for evaluation of overall survival, and you can see when it became mature, it did clear the pre-specified endpoint and was declared positive. So here's an example of how this played out with respect to progression-free survival. Both of these were highly statistically significant. As I mentioned, both of these were analytical. And if we add this to our categories here, you can see that this was a consistent finding across all of the chemo-IO endpoints. I put down in red the informative fraction for the overall survival data that will be updated hopefully soon. We'll hopefully try to dig it out of Dr. Rama's discussion. But ultimately, this maturity and informative fraction become very important. So if you're not familiar with these terms, you see them all the time on statistical presentations. But I just want to put them down here so you've seen how these are defined. Maturity represents the number of events that have happened over the patient population that was enrolled. So if it was 250 events out of 500 patients, it was a 50% mature. It's always going to be less than or equal to 100%. The informative fraction, though, is based on the statistical design for the minimum number of events that you needed to have happen to have the power to make the assessment, that beta error. We wanted to have the power to have confidence in rejecting null hypothesis. And so the informative fraction is the proportion of events that have happened when you looked at the data relative to that point that you were trying to get to. And generally what we try to do is we want to have about 80% of the data, of the information to declare or to look at the data confidently that we're actually hitting our endpoint. So to put this into perspective, this is the Ruby trial for overall survival. You can see that these are the overall survival is the endpoint in the all-comer population, and there were these interim analyses, 3 of them, and then a final analysis. And you can see that the number of events based on the informative fraction at the first look was at 51%. There's that p-value category I said that was the critical minimum that it needed to beat, and it didn't. So that amount of alpha was then subtracted to the available alpha left to make that a point at a later analysis. And you can see at the IA2, there needed 221 events, which they had, and the p-value that for stopping at that point was at 0.006. And if you remember on that graphic I shared, it was 0.002. So it cleared that endpoint with only 68% of the informative fraction. And that's why it was declared and reported out as a positive endpoint for overall survival. So here's what these look like. And I always like to look at these curves sequentially to kind of see what happens as more of the events become uncensored, so they have occurred. You can see that there's a lot of uncensored events. Those are the little tick marks that are on the tails of the curves. And you can see that as that became more mature, the morphology changes a little bit, but you can see how it was then evaluated with that p-value of 0.02, which was statistically valid. Now, what you do see a lot, and this is one of my pet peeves, is that you do see a lot of p-values applied to non-analytical endpoints. And we see this frequently. In the ITT population of Ruby, the p-value was valid because it was statistically powered for an overall survival in the ITT population. However, there is a report of looking at the dMMR population in this particular analysis for overall survival, and you can see there's a nominal p, and as you can see, it looks very significant. So the incorrect conclusion here is to say, well, this is statistically significant in this subgroup. It's not. It's very highly suggestive it could be because it's hypothesis generating, but it's not an analytical endpoint. So there's not been appropriate allocation of the probabilities of being right or being wrong to this particular analysis. However, obviously this would have high likelihood to be positive if it were formally evaluated. And the last thing I want to just mention is this informative censoring. This is a complex topic, but I think you can get it. If you can imagine that if there's an event for progression-free survival, you're waiting for a progression event or a death event to actually say that something happened. That's when it becomes an uncensored eval. But then sometimes when there's an availability of the alternative medicine or patients can cross over without actually achieving that endpoint, it can confound the analysis, right? If you can imagine somebody on the control arm said, listen, I'm done with this. I'm just going to take an immune checkpoint inhibitor. Well, that would essentially cause us to censor that patient at a point in time, and then what happened afterwards is going to be completely left up to what happened with what they took. And so there's a way that you can actually statistically evaluate how much bias that introduces into the study based on the proportion of patients that do that. or that have that problem going on. And so that's what you're seeing over on your left, or my right. No, your right. On the right-hand side, as you can see that if there's a non-protocol therapy that's 10% of the population, the bias that's introduced is about 20%. Once it gets above that standpoint, it becomes it can be very inconclusive because of the amount of bias that's being introduced because of this non-protocol therapy or crossover. Sometimes trials that are so toxic will cause patients to discontinue therapy before progression because of toxicity. That's another form of informative censoring. So, and you can see what that relationship is as time goes on. Fortunately, these trials were well conducted. They were well planned out. They brought a hypothesis forward. They were appropriately designed. They were a home run. So those of you who know baseball, that's what that is. And those who know this guy, Ohtani, this was his third home run on that, and he also pitched that game. So but again, you gotta love an idea that started in the lab as a hypothesis. It was proved in as a single-arm trial for hypothesis generating. Went to a phase 3, was formally evaluated, and actually hit its primary endpoint. And with that, I will close. Thank you so much.
Thank you so much, Dr. Coleman, and a special thank you for recognizing the Dodgers who won the World Series. Of course. So I have the opportunity to talk about biomarker strategies and looking at subgroup data. And for many of you who were in the endometrial cancer master session earlier, some of this will be review, but repetition is the branding iron of knowledge, I like to say. I would also like to just reiterate that as we think about biomarker data, we have to be very thoughtful in how we analyze, interpret, but use this data to hopefully inform the design of future clinical trials, as Dr. Coleman taught me over my life. So this is a table that summarizes how we got to where we essentially emerged with what I referred to earlier as the legacy regimen of carboplatin and paclitaxel. And I really put this up to highlight that this was in an era of disease homogeneity. Rob kindly shared with you guys the TCGA molecular subgroups. We have the PROMIS algorithm that's being incorporated. But the word I use is we've gone from disease homogeneity, trials that were conducted because we didn't have insight into molecular information, aggregating all the different endometrial cancers together, and then using that data to drive the science. But we've moved well beyond that, and now we are in an era of disease or molecular granularity. We're doing our best to understand how the molecular underpinnings of the disease can inform therapeutic treatment opportunities. I had mentioned earlier that the cohort of patients enrolled on GOG 209 with recurrent or metastatic disease did exceedingly poorly, highlighting the unmet medical need. And we began to understand how we could target molecular aberrations by adopting treatment paradigms from other tumors. And I think one of the great advances in solid tumor therapeutics is what I call the promiscuity of drug development now. Whether you're treating breast cancer or lung cancer or colorectal, as we know from the DMMR, endometrial cancer, we've seen an evolution of capitalizing on biomarkers to help drive drug discovery. And the data from the HER2 trastuzumab clinical trials by Dr. Fader tried to usher that paradigm into our disease setting. So understanding that this was a randomized phase 2 clinical trial, as I shared with you earlier, with 58 patients, nonetheless, it helped us understand that we can use HER2 as a biomarker in these serous endometrial cancer patients to try to identify a novel, effective treatment opportunity for a patient cohort that clearly reflected an unmet medical need. And this resulted in the United States an NCCN compendium listing and the incorporation of trastuzumab in the treatment of such patients based, again, on breast scoring. But, of course, since that time, we've identified mismatch repair deficiency as a very strong biomarker, not just in endometrial cancer, but across solid tumors. I would just like to remind us in the room, the very first ever disease site agnostic approval in solid cancer therapy was pembrolizumab in mismatch repair deficient recurrent solid tumors. And it was a paradigm shift for us because it was essentially laying the foundation for what we would see over time when we identify biomarkers that truly are predictive of an efficacy and then confirming it in appropriately designed clinical trials. But unfortunately, in the mismatch repair proficient cohort, single agent immune checkpoint inhibition had a much more modest efficacy response, ranging from about 8 to 12%. So clearly, insufficient driver of response in this patient population, mandating us to look at alternate treatment strategies. We also learned that mismatch repair deficiency amongst all solid tumors was greatest in the endometrial cancer population. And so we wanted to capitalize on the frequency of that molecular aberration to improve clinical outcomes. We've referenced these trials. Dr. Coleman did a deep dive into the design and development of NRG-GY018 as well as the RUBY trial, but there were two additional important studies, the DUO-E study and the ATTEND. And again, Dr. LaRusso said this earlier, these 4 trials were conducted simultaneously, internationally, in parallel, and overlapped the pandemic, but were still done and accrued, much of which ahead of what was anticipated. So a testament to the work of everybody in this room and globally, resulting in the publications and ultimately our identification of the efficacy in the DMMR population, again highlighted here, recognizing that there's still work to be done in about 25 to 30% of patients who progress despite having the biomarker, but having regulatory approvals for chemotherapy plus immune checkpoint inhibition, followed by immune checkpoint inhibition maintenance in metastatic and recurrent mismatch repair deficient. But you would be appropriate to then ask me, Ramez, what do we do for those patients who have mismatch repair deficient disease, high risk, completely resected? The Keynote B21 study, which was also reviewed in the master session, was designed as an adjuvant study in patients with completely resected high-risk disease. It's very important to recognize that the eligible patients in this trial were quite heterogeneous. You can have really any histology, P53 mutated with any degree of myometrial invasion, or you can have a serous endometrial node positive completely resected. That is a very diverse portfolio of patients to put on a clinical trial. Randomized to carboplatin and paclitaxel, pembrolizumab maintenance, carboplatin, paclitaxel, placebo maintenance, with radiation at the discretion of the physician. I will say this was a clinical trial that had a substantial international accrual, and radiation was incorporated in about 3/4 of patients, 75%. And what we saw in the intent to treat population, this was a negative trial. They did report the efficacy signal in the pMMR and the DMMR population. And the reason I bring this up is because I'm going to be obligated to answer this question in clinical practice. In a completely resected mismatch repair deficient patient, where the hazard ratio of disease progression when I use chemo plus pembrolizumab in maintenance pembrolizumab is 0.30, with the validity of that biomarker and with the data that we have in the metastatic recurrent setting, what do I do? Because this was not a pre-specified alpha allocated endpoint, as Dr. Coleman taught me. So I have to be thoughtful about interpretation of this and potential false discovery. But in the same breath, I recognize the strength of that biomarker across many disease settings. So to be provocative, I've overlaid here on the bottom right the Kaplan-Meier curves of the Keynote B21 study and the GY018. Both chemo, pembro maintenance studies. And I will say that the morphology of these curves is not the same, meaning would I wait for a completely resected DMMR node positive patient to recur before challenging them, or should I give them the best effective available therapy at that time? And we have cases that we're going to discuss as a group with Dr. Pathuri to talk about the relevance of this biomarker in informing the treatment strategy. And I will also ask everyone in this room to think about what we did with PARP inhibitors in BRCA mutated patients after the publication of SOLO-1, and in which patients did we use these targeted biomarker-directed approaches. In the pMMR population, it's more nuanced, as we already discussed, and there are many reasons why that might be the case. But the efficacy signal in the mismatch repair proficient cohort, and as was reviewed by Dr. Coleman already in NRG-GY018, this was a completely independent examined population. But the efficacy signal in both the NRG-GY018, in the RUBY study, in the cohort in the DUO-E population showed a very consistent signal, and this resulted in the regulatory approvals with both pembrolizumab chemotherapy and dostarlimab chemotherapy, followed by checkpoint maintenance. Now, what about HER2 as a biomarker? We've discussed the Destiny Pan-Tumor02 data. We recognize that in the 3+, the ORR was 84.5%, which is a number that is dramatically higher than what we have seen in prior studies looking at single agents in a biomarker-directed population. Is this driven predominantly by the HER2 3+? What's the information we're going to gain by enrolling and treating HER2 2+ and potentially even 1+ patients on trial is yet to be answered. And as I alluded to previously, when you look at the central adjudication, the total number of patients that are 2+ and 3+ was 30 total patient subjects enrolled. Nonetheless, because of the totality of the data from the Destiny Lung, the Destiny Colorectal, and the Destiny Pan-Tumor02, the US regulatory authorities provided a disease site agnostic approval in the HER2 3+ population with TDXD with recurrent metastatic disease. And this was a small population of carcinosarcoma patients enrolled in the status trial, all Japanese sites as I alluded to, showing efficacy irrespective of HER2 IHC expression levels, 1+, 2+, 3+, in a disease, histology, carcinosarcoma, that is traditionally not as responsive to systemic therapies. But we have to ask ourselves, are there biomarkers beyond mismatch repair status, specifically mismatch repair deficiency, and HER2? This is the question we ask ourselves because, as I alluded to, we've ridden this train from lumping all of these histologies together, again, disease homogeneity. We've gone to molecular granularity. We're learning more from other solid tumors. It's compelling us to ask the question, are there other biomarkers that can refine our treatment decisions to do best for our patients? So let's follow this path and see where it's led us to date. The first was the molecular classification algorithm from the RUBY clinical trial presented by Dr. Mirza. This was whole exome sequencing conducted on 80% of the patients that were enrolled and treated on trial. It used the PROMISE cohorts, the POL-E, the P53 mutated, the TP53 wild type or NSMP population, and then of course the mismatch repair deficient cohort. You can see very consistent, the POL-E, remarkably good clinical outcomes. The mismatch repair deficient population, consistent with the primary hypothesis that you guys have seen already. But what was perhaps most provocative were the two Kaplan-Meier curves on the bottom. On the left, the TP53 mutated, on the right, the NSMP cohort. And the suggestion with presentation of this data is that, well, we found our answer. We're going to use chemo, checkpoint maintenance in the TP53 mutated population that's mismatch repair proficient because of these findings. But I caution us, because as I alluded to earlier in the master session, we do not know which patients fall into each of these respective buckets, and there can be multiple confounders that we have not yet allocated, and we don't compare for we have not controlled, for multiple comparisons when we do analysis like this. And it also appears to be driven by poor performance of the control arm in the TP53 mutated cohort rather than lack of efficacy of the intervention arm. Thankfully, Dr. Weston and colleagues also did biomarker exploratory subgroup analysis from the large DUO-E randomized clinical trial. Here we had 486 patients, again, a very meaningful population. Approximately 85% of the patients enrolled had molecular assessments. And what we can see here, this Venn diagram that overlies, the most common molecular aberrations that were reported here were PD-L1 positivity in approximately 67% of the patients, and TP53 mutation in approximately 60%, 59% of the patients enrolled. Additional biomarkers were homologous recombination repair gene mutations, BRCA mutations, and you could see POL-E exceedingly rare, and you'll see this consistently across our studies at approximately 1% to 2%. But if I coalesce these trials now, if I bring in DUO-E, RUBY Part 1, the UTOLA, which looked at a maintenance PARP inhibitor strategy, and the MITO-N3 study, which was an avelumab checkpoint study, you could see that the frequency of P53 aberrations was actually consistent for 3 studies and lower than what we may have anticipated for RUBY Part 1. So firstly, we're not seeing necessarily a consistent signal with biomarker across our studies. And then if we look specifically at the subset analysis in DuoE, if you look at the chemotherapy durvalumab maintenance, you could see that TP53 wild type was associated with an improved response. And on the bottom, BRCA mutation status was associated with an improved response. So I've highlighted for you already the subset analysis in TP53 from Ruby. That appears to be discordant from the subgroup biomarker assessment in DuoE. But then if I look at the durvalumab plus olaparib arm of DuoE, TP53 mutation now appears to be associated with an improved response. So we have this really significant heterogeneity. We have lack of consistency across the biomarker predicting response. And on the bottom panel, we may have hypothesized that you're going to see a more magnified response with olaparib in a BRCA mutated endometrial cohort, but we didn't see that. So the reason I say this is I feel like collectively, this obligates us to be humble about subset assessments driving biomarker drug discovery. This is hypothesis generating data. This is data that we need to take, and if we truly believe that P53 defines response, we define and develop a study with that as the primary efficacy endpoint, because otherwise we put ourselves at risk of withholding an effective treatment from a patient in clinical practice without having the data that we need to confidently make that clinical assessment. The same thing here for PD-L1 status. If we look, PD-L1 appeared to be a biomarker predictive of response in the DuoE study. You can see in that middle panel, hazard ratio of 0.71 with a positive PD-L1 TAP score. But on the bottom two panels, on the bottom left in the NRG-GY018, on the bottom right in Ruby Part 2, which was incorporated niraparib plus dostarlimab, PD-L1 expression levels by CPS did not appear to be at all predictive of therapeutic response. So again, we have very dichotomous outcomes data in assessing this as a biomarker predictive of efficacy. So as we think about this, and as I try to synthesize, what is the relevance of biomarkers with endometrial cancer? In our present state, I will say we have great confidence that tumor mutational burden high is a predictor of response to immune checkpoint inhibition. We saw earlier from the case that was shared by our colleague that a POL-E mutation, very high TMB of 256 mutations per megabase, had a dramatic response to immunotherapy at recurrence. We know that MMR, in a similar manner, is predictive of response to immune checkpoint inhibition across solid tumors. We recognize the relevance of HER2 as a biomarker. It emerged in the Destiny Pan-Tumor-02, but also Destiny Lung, Destiny Colorectal. You have a consistent efficacy signal across multiple different studies. And we have a disease site agnostic approval with HER2 3+ by gastric scoring. But on the right side, are we using HRD in endometrial cancer to inform therapeutic treatment strategies? If you have access to durvalumab plus olaparib, what information does HRD add, and how confident can we be that it is an accurate biomarker? We talked about estrogen receptor and progesterone receptor. I will tell you right now that there are trials in development where ER positivity is defined as 1%, it's defined as 10%. How am I going to adjudicate this? What am I going to do in clinical practice? And what is the right threshold, the cutoff, if we're going to employ it as a biomarker? PD-L1, as I alluded to a slide ago, has very heterogeneous efficacy, predictive ability, because in some trials it appears to be informative, in others there's lack of information predicting response. And lastly, TP53. And one of my favorite quotes from Ronald Coase, he's an economist, says, if you torture the data enough, it will confess to anything. And I think that we have to remind ourselves of this every day, because you guys will look at data output, I look at data output, we see forest plots from clinical trials, there are subsets in these forest plots, conclusions are made, but are these the accurate conclusions? And there's a term actually in biostatistics called hearkening, which is hypothesizing after the study results are known. And I will just give you an example. If you take data that's resulted from a clinical trial, and you then go back and you do 10 comparisons of the primary endpoint that you've defined, there's a 40% chance you will have a false positive finding. So what does this mean? This doesn't mean that we are not interested in defining biomarkers and moving the science forward. That is not the take-home message. The take-home message is there are biomarkers. We are becoming more informed as a subspecialty in identifying what these biomarkers are. And now it is our obligation to take these biomarkers to develop the right clinical trials that are going to give us confidence and hopefully inform effective treatments. Because as Dr. LaRusso stated, not long from now, we're going to have multiple antibody drug conjugates, and many of these may be improved in clinical practice. And we're going to be left in front of the patient who's sitting in the chair in our room, and they're going to ask us, what strategy is best for me? And honestly, I will humbly say that I'm hoping all of us will sit together and figure this question out. Thank you for your time, and it is my honor to present Dr. Pathuri for her case presentation.
Okay, that was great. We are going to move on with some cases, and I'd like everyone to scan this QR reader. You'll only need to do this once because we're going to make this interactive, and I'm going to ask for responses in terms of management. So go ahead and scan that. I'll give everybody just a minute. Okay, great. So let's start with case 1. So this is a 48-year-old with a family history of colon cancer, breast cancer, and bladder cancer who presented with irregular vaginal bleeding. Her endometrial biopsy showed an endometrioid endometrial cancer with loss of MSH6 on immunohistochemistry and HER2 1+. She underwent a robotic hysterectomy, bilateral salpingo-oophorectomy, and sentinel lymph node biopsy. One of her right pelvic lymph nodes was positive for micrometastases, so she was staged as a 3C1 back in December of 2021. Her genetics confirmed Lynch syndrome with an MSH6 mutation, and she was instructed to tell her family members to undergo cascade testing. She undergoes chemotherapy with paclitaxel carboplatin for 6 cycles. 18 months after completion of her chemotherapy, the patient presented with a persistent cough. Her CT scan confirmed multiple pulmonary nodules, and a biopsy confirmed recurrent endometrioid endometrial cancer. So, how would you treat this patient? So it's a DMMR completely resected 3C1 with tumor recurrence 18 months after completion of chemotherapy. So retreatment with paclitaxel carboplatin. Are you guys all seeing the poll? Great. Paclitaxel carboplatin, dostarlimab or paclitaxel carboplatin pembrolizumab, dostarlimab or pembrolizumab, doxorubicin or weekly paclitaxel, lenvatinib, and pembrolizumab. Okay, please. All right, so looks like our responses are coming in. So what would you all do? Ramez, Rob?
Start, Rob?
Either.
Yeah, I think in clinical practice, we have great data. Now, as we spoke about, we have yet to see the single agent data from the frontline studies in the mismatch repair deficient population. In this scenario, clinically, based on the data that we have, the strength of the data, the number of patients treated, I would probably go with the majority of the audience here with chemotherapy, checkpoint, and followed by checkpoint maintenance.
I would agree. I think that it's very intriguing, though, to look at a single agent. I mean, obviously, a lot of us would like to do that as a single agent with IO, but with a Lynch syndrome patient, I think that's still where our standard of care would be.
Great. So this patient undergoes paclitaxel carboplatin and a checkpoint inhibitor, followed by maintenance checkpoint inhibitor for 2 years. And, you know, I'm just going to flash this up. Ramez already went through this in detail. We have incredible evidence for treatment with this regimen. And I also wanted to pop up the B21 data that Ramez alluded to. While this data was not available at that time when she was treated, this is certainly something that I personally would consider in my practice if I were to treat her today. Would you agree? I see Ramez shaking his head. Rob?
Yeah, I mean, I think, like I said, I think this would be compelling. It's unfortunate that this trial was designed this way, because I think there's a good chance this would have been a positive analytical endpoint had we done that. But yeah, I think this is very compelling. And we'll have some data that'll come. This is one of several that are working their way through. And I think the maybe even a more interesting potential question is that in those that you think radiation therapy is a viable option, is to figure out what this would in an IORT strategy.
Yeah, great thought. So what if this same patient recurs with pulmonary nodules within 6 months of completion of primary chemotherapy? Okay, so
It's like a horse race
I
watching.
know.
so it looks
You want to
like,
restate what the question was?
so the question is, in this patient with DMMR, recurrent DMMR, endometrial cancer, who completed chemotherapy, but she recurred
Within
6
6
months.
months.
Yes. Same patient.
Yep.
And it looks like the single agent checkpoint inhibitor won.
This is almost like that case that we had presented at the beginning of the last session. A patient who is almost the same thing except she was a pol E. But I think it does highlight the value that single agent therapy can do to shrink tumors, which was the slide you and both of us showed, that they can achieve a decent amount of responses.
Great. So this patient did receive single agent dostarlimab and had complete resolution of her disease at 6 months. And this is just to remind you of the Garnett data that Ramez went over, showing significant efficacy with single agent dostarlimab in the recurrent setting and was FDA approved. And similarly, we have pembrolizumab as an option with Keynote 158 with similar efficacy and also FDA approved. And just one last point with this case. How long do you all continue your checkpoint inhibitor? For 2 years, until progression, until CR, 1 year, 3 years. Oops, sorry, let's see. Okay.
Now we'll be able to see which of you use which trial, because as you remember, Ruby and GY018 had different endpoints, and then DuoE and Attend had until progression. So we'll see.
Okay, so looks like the majority picked 2 years.
Surprisingly little at 3. I think it would be different in the States. You think?
I don't know.
Yeah.
What?
For 3 years, 3 years of use, which would, I would expect that to be more.
I think this is reflective of collectively, there's this, we have an appetite for de-escalation.
Yeah.
And I think what we're seeing to a certain degree is this, the narrative that is, how long do we want to treat for when we have a patient who responds, has a complete response, and we believe, may not require additional treatment.
Yeah, you showed that slide, which I love, which highlights the kind of like 2 phases in the DMR population with exposure to IO, the chemo IO, like right at the, after that first 25% of patients that progress relatively consistently over the first 12 months, you'd see almost no events afterwards.
Right.
It goes completely flat. So there's this like separate population in there that has done extremely well. And so the question is, how long do you keep going when you've already kind of achieved that? Do you go 2 years, 3 years on till progression?
Yeah, I think we really need to start thinking about incorporating ctDNA into our trials prospectively to try to really optimize our treatment length. Okay, let's move on. Case 2, 80-year-old Ashkenazi Jewish patient with a history of postmenopausal bleeding, went to the ER, had a CAT scan that showed a distended endometrial cavity and inguinal and left pelvic sidewall adenopathy. She had an endometrial biopsy. that showed endometrial adenocarcinoma, endometrioid type, FIGO grade 2, P53 wild type, MMR IHC intact, microsatellite stable. So she was planned for an exam under anesthesia, a palliative hysterectomy, an excision of her lymph node. And when we went to the operating room, she had extensive disease in the pelvis and her abdominal wall surfaces that were covered with tumor plaques, and the rectum and bladder were densely adherent to the uterus. So the decision was made to abort the hysterectomy and just proceed with excision of that groin node and a DNC. Her tumor was sent for foundation. You can see here that her tumor was confirmed to be microsatellite stable, and she had this mutation profile. She was a stage 4B endometrioid grade 3 HER2 1+. So how would you treat this patient? So paclitaxel carboplatin followed by selinexor maintenance, paclitaxel carboplatin, paclitaxel carboplatin immunotherapy, followed by maintenance immunotherapy, and paclitaxel carboplatin or trastuzumab. So to recap, stage 4B, P53 wild type mismatch repair proficient endometrial cancer, grade 3. Okay, so seems pretty consistent. The majority is picking paclitaxel carboplatin with the checkpoint inhibitor. Is that what you all would do?
You know I'm totally biased here.
I know you are, that's why I'm asking.
Being the PI, GOG PI for the X40C trials, I think Ramez brought up a really super point, and I think we try to drill this home, is that we use these subgroup analyses as hypothesis generating, try to find the biological rationale that supports that. Selinexor, I like from the mechanism of action with the wild type P53 signature, so we know that the protein is functional. And so the idea here, the hypothesis again, is that it would make that work. But again, as I mentioned with my other example this morning, is you take a hypothesis generating element and then you form a phase 3 trial, positive or negatively. That's just appealing because you're going to address a question and then that's done. So that's why I like that. That would be my choice.
So are you telling me you're going to use the SIENDO data to treat your patient?
No.
Maintenance selinexor?
No. I said participate in the trial.
Yes.
So you'd put her on trial.
Yeah.
Okay, I like that. Okay, next. All right. So the patient actually did start on the RUBY trial. She received carboplatin, paclitaxel, and dostarlimab. She completed her 3 years of dostarlimab in November of 2023. At that time, her CAT scan noted some residual disease in the uterus, and she actually had a ctDNA drawn that was low positive, 0.08. She was advised to undergo hysterectomy, but she declined as she was concerned about her health and her ability to tolerate surgery given her age, despite her excellent performance status. She therefore opted to follow up. She had a repeat PET scan 4 months later. That was essentially stable with metabolic activity in the uterus and no other evidence of active metabolic disease. She had a ctDNA drawn at that same time where it had doubled. So it went from 0.8 to 0.16. At this time, the patient agreed to surgery. She underwent an EUA robotic hysterectomy and extensive lysis of adhesions. And she did have some dense adhesions, but the surgery went fine. And she had really an excellent response to treatment and no other visible evidence of disease at this time. Her pathology came back as an endometrioid adenocarcinoma with 60% myometrial invasion, no LVSI, lower uterine segment involvement, and she also had cervical stromal involvement, 0.4 centimeters out of 0.9, and the margins were close at the deep and at the vaginal resection margin. She, again, had a P53 wild type on IHC. Her mismatch repair IHC was intact, HER2 2+, and her post-op ctDNA was 0. So what would you do at this time? So this is, to remind you, a P53 MMRP stage 4B, underwent neoadjuvant chemotherapy, completed her treatment on the Ruby trial, and now had a hysterectomy. So, do you treat with chemotherapy, doxorubicin or paclitaxel, pelvic radiation with external beam with vaginal brachytherapy, external beam vaginal brachytherapy plus chemotherapy, paclitaxel, carboplatin, and checkpoint inhibitor, paclitaxel, carboplatin, lenvatinib, pembrolizumab, paclitaxel, carboplatin, followed by selinexor, or no further treatment.
Bhavna, can you say that she was unblinded, so you knew that she got dostarlimab or placebo?
So she received dostarlimab.
Okay.
This is great.
Mm-hmm.
Okay. So it looks like we're kind of split with the no further treatment and some local treatment.
Mm-hmm.
Yeah. What would you do, Ramez?
I think, well, firstly, I think the beauty of this case, and this again was a concept that was alluded to, is this incorporation, because we're seeing so many endometrial cancer patients with advanced stage disease de novo in the neoadjuvant setting, and seeing efficacy in a patient where, again, if you were to look at the conglomerate data that we have, someone could argue, well, you won't necessarily see a response in this patient because they don't have a quote-unquote biomarker predictor, but you had a dramatic response in this patient
Well, I'm gonna
who
show
had
that.
clinical benefit. So I, to be honest, I think the first two, where 85% of the cohort appears to fall, make a lot of sense in this case. I think you had some surgical risk factors. I apologize if there are radiation oncologists in the room. I would probably, in this setting, advocate for observation, understanding that vaginal cuff brachy is certainly reasonable because of the close margins that were there
that was
surgically.
Yeah, that would be persuasive to me because it's always hard to clear disease, just as you saw with all that immunotherapy that she still had disease in the uterus. It's very hard to clear a disease out of tumor. You were close on the margins there, so that would be my. Vaginal brachy.
Vag brachytherapy. Okay. So she was counseled about chemotherapy options. She declined. We discussed pelvic radiation, external beam versus vag brachytherapy, and with her radiation oncologist, and she received vaginal brachytherapy. She completed that in June of 2024, and as of her last follow-up, she continues NED. So, again, I want to point out that, this would have been a perfectly reasonable trial option for her on Export EC that Rob actually alluded to, given her P53 wild type after she completed chemotherapy. In addition, I want to, this is back to Ramez's point where I really want us to be cautious about utilizing post hoc subgroup data. This patient clearly benefited, and it's just a real life example of why to be cautious and not use this data to guide your treatment decisions. How are we doing time-wise? Oh,
We're okay. We're okay.
we're good. Okay.
We're okay.
So if she relapses, your next option would be either doxorubicin or paclitaxel clinical trial with a TROP2 or FR alpha ADC, or best supportive care. Okay. So we have 3/4 saying a clinical trial with TROP2 or FR alpha ADC. That's great.
You can see how negative it is for single agent chemotherapy. I mean, this patient's now like in her mid-80s, right?
Yeah.
She's 80.
Yeah,
but
yeah,
she's got,
yeah.
She was a substitute teacher doing,
Full-time work.
going in to teach. So,
Love it.
And I wonder how many of the best supportive care may evolve to the top option if they had access to the trials. Meaning,
Yeah.
is it best supportive care because they just don't have access to the trials examining TROP2 FR alpha? See, I don't know.
Yeah.
right. Or, yeah. That's a good point, Ramos. So in terms of the trial options, we have 2 randomized phase 3 trials of a TROP2 ADC in recurrent endometrial cancer. Both you see here. In addition, we also have a phase 3 trial targeting FR alpha ADC, Rainfall 03. So these are really great options for this patient should she relapse. Are we done?
Yep. No, we're good.
Okay, great. We keep going?
Yep.
Yeah,
We got about
okay.
15 minutes.
All right, perfect. So we're moving on. Case 3, this is a patient with P53 abnormal, mismatch repair proficient endometrial cancer, 76-year-old with diabetes, hypertension, Hashimoto's, who presented with postmenopausal bleeding. Her endometrial biopsy showed an endometrial carcinoma consistent with high-grade serous cancer, P53 aberrant on IHC, MMR IHC intact, HER2 3+. Her CAT scan showed a big uterus, no adenopathy or distant disease. She underwent a robotic hysterectomy, BSO, sentinel lymph node. Her pathology showed 99% myometrial invasion, LVSI, lower uterine segment involvement with cancer, no serosal involvement, and she had a left external iliac sentinel lymph node that was positive for metastatic serous carcinoma. So this was a stage 3C1. You can see her somatic molecular profile down below. And how would you treat this patient? Paclitaxel, carboplatin, trastuzumab, trastuzumab deruxtecan, or no further treatment. So this is a P53 MMRP patient,
HER2 3+.
HER2 3+.
3+.
That's right. It was all negative. Yeah, it's just not on here. Okay. So, what is it? It looks like
Yeah,
everybody
most.
picked paclitaxel.
Trastuzumab, yeah.
I wonder if this is also the same
Carboplatin,
like the last one.
trastuzumab.
Availability, yeah.
Okay.
What'd you
Yeah.
say, Bob?
This is like the last where it's not available.
Yeah.
Yeah.
So the patient actually participated in a clinical trial, GY026. She was randomized to the carboplatin paclitaxel trastuzumab arm, and she continued on trastuzumab maintenance with progression of disease. And this is the NRG GY026 schema, the study that's ongoing, where patients are randomized either to carboplatin paclitaxel, the combination of carboplatin paclitaxel with trastuzumab, or carboplatin paclitaxel trastuzumab pertuzumab. So now that she's progressed on chemotherapy and trastuzumab, how do you treat her? Lenvatinib and pembrolizumab, doxorubicin or weekly paclitaxel, trastuzumab deruxtecan, or paclitaxel carboplatin with checkpoint inhibitor followed by maintenance checkpoint inhibitor.
And remind me how many months?
What's that?
How many
How many
months?
months after was she on maintenance before she progressed?
She
10 months, I think?
I think so.
Okay.
So looks like lenvatinib pembrolizumab wins. Yeah, this is someone who's IO naive.
Mm-hmm. And I think also to the point made earlier, availability and access to TDXD, if it's available regionally or not, would impact that.
But to your point too, there were, how many patients in PanDestiny-02 that had 3+?
I think they were
13
and 17.
It's
11
13
of
patients.
13
You're making
responded.
versus a phase 3 trial that has a PFS and OS
Correct.
and objective response. Yeah. No, we see the same thing. There's just it's attractive, but the patient coming off of trastuzumab, we don't know.
Correct.
Yeah. So, right, this is the lenvatinib pembrolizumab keynote 775 data, as Rob said, right? Randomized phase 3 data, both PFS and OS benefit. And we also have TDXD. And as we said, right, overall 57% response rate, but in the 13 patients who were HER2 3+, it was 85%. And the other thing I wanted to go over for this patient is she's also a candidate for 2 clinical trials that are currently ongoing. Destiny Endometrial 01, which is a randomization of Enhertu and Rilvi, or Enhertu and pembrolizumab, or carboplatin and paclitaxel and pembrolizumab. Since she was treated in the adjuvant setting, and this is her first recurrence, she would be eligible for this trial. And she's also eligible for Trophuse 033, which is a randomization of a TROP2 inhibitor. It's carboplatin paclitaxel. And then if without progression of disease, they get randomized to sac-TMT plus pembrolizumab versus pembrolizumab. And then if they had progression, they continue on sac-TMT and pembrolizumab. So this patient actually started on TDXD in October of 24 and continues on treatment and has a PR. And so she does have other treatment options if she progresses. And that's it.
Wonderful.
Thank you.
Okay, thank you, Dr. Pathuri. We will open up to questions from audience members. We have time for Q&A.
Yeah. Maybe I
Submissions.
can start a little bit of the discussion. We didn't talk about bevacizumab in the MMRP
Population.
p53 mutated cohort. Any thoughts about when you might use bevacizumab in endometrial cancer patient? Either one of you?
I mean, I think, as we alluded to, there's some data that suggests that it can be used. There is, what I'm eager to see is the activation of the clinical trial.
Right.
That's going to help us more definitively, answer the question of the utility of bevacizumab. Mm-hmm. We have it as an NCCN compendium listing in the United States. Now, whether or not there will be broad utilization or uptake currently, or do we wait for the data to read out, I think is an unanswered question. I currently, in clinical practice, I don't use very much chemo-bev maintenance in endometrial cancer.
I've used it as a single agent.
Oh, yeah.
Yeah, and
Correct.
I find patients tolerate it really well, and I get, a lot of stable disease with it. Some mild partial responses, but it's a treatment option that I do utilize.
Go ahead.
Hi, I have a question. In the Keynote B21 trial for high-risk endometrial cancer, there were 281 dMMR patients in total, but only 65 were in stage 1-2.
Mm-hmm.
These 65 patients had just 4 disease-free survival events, and all in the placebo group. So, would you consider combining immunocheckpoint inhibitor with chemotherapy for this population?
Yeah, such a good question.
Yeah, it's so hard to answer.
I will say that in an earlier, I think what's going to happen, my hypothesis, I don't know if this is true, we have a cooperative group study in the United States. It was an NRG GY020, which was in the high intermediate risk DMMR. vaginal cuff brachy versus vaginal cuff brachy followed by pembrolizumab. If that trial ends up being positive, and now we have a very early study that's positive for the clinical outcome, and we have this subgroup of B21 knowing its hypothesis generating, and we have the data from RUBY and 018 and ATTEND and DUO-E for the DMMR, I think at that point we will have bookended the very beginning of any systemic therapy and the end, and we will fill in the difference by using IO because clearly we will have shown it across the board. I think right now there's some reluctancy because in the same breath, there's concern that could we be changing the biology of the disease in some way early on if we use it in these patients? Maybe they don't need it. But I think as those studies mature and read out, we'll have our answer. I think, I don't know.
Yeah, at present, I don't use it in the early stage.
Stage
Just
1 and 2.
That's right. Yeah, just because the risks, IO has risks, and I'm going to be doing a whole talk on chronic IO toxicity soon, so that scared me.
Stay tuned, yeah. Stay tuned. Yeah, and we also have C93 that will be potentially coming, that will potentially add evidence to this whole dynamic in the DMMR.
But I love the question.
Yeah.
There is a question that came in about ctDNA. Oh, I'm so sorry.
It's okay.
Yes.
So, hi. My name is Anita. I work here in Canada. I have a question about clear cell carcinoma. So if the histology is clear cell and there is a residual carcinoma in hysterectomy, but there is no myometrial invasion, do you offer any adjuvant treatment? Early stage, obviously. Not.
Early stage
So
clear cell with no myometrial invasion.
completely staged, clear cell, no myometrial invasion. Do you offer systemic therapy is the question?
Yes.
In the absence of knowing what else to do, I do. Because I think the potential for distant failures is high.
I do the same thing. I give chemotherapy.
But I don't have a good reason for it.
Okay, because in our center we have a debate about giving them radiation because clear cell is less sensitive to chemo.
I think that's another one of those statements that just got over. It's a soundbite that I think's got over emphasized. I don't know that it's that they're not sensitive to chemotherapy. And if you're the way I would look at this is, what do you think is your at-risk area? Is it cuff? Is it abdomen? And if it is, what are you using radiation to cover?
That's the debate with the serous carcinoma, carcinosarcoma, and clear cell. And this is why I think we used, but NCCN guideline, we looked at it, and it says observation, or vaginal brachytherapy, or systemic therapy.
Yeah, get your choice.
You're exactly right, and I think that appropriately summarizes the lack of prospective data to inform what to do in that setting. I think that's the perfect place for us to design trials using ctDNA, for example, to help guide whether or not those patients would need any adjuvant treatment, meaning prospectively operate, assess, randomize, and then follow clinical outcome in the ctDNA positive and negative to figure out, do we need to treat these patients if their ctDNA is negative? And Bob has been working on a proposal similar to this.
Okay, thank you.
You're welcome. Try one more time.
Can you hear me?
Yes.
Thank you. Great presentations. So my question is about the non-DMMR advanced patient populations. And the current studies like GY026 and the selinexor study, they don't randomize to immune checkpoint inhibitor plus chemotherapy. The standard of care in those studies is chemotherapy or placebo-made. So how are you juggling those options with your patients if you have someone with a non-DMMR cancer, but they have one of these other biomarkers? I'm just interested to grill you all on what you're doing in the clinic setting if you have options for these trials.
Well, I'll just say, I think it takes a lot of counseling with the patient. Remember the EXPERT-EC trial is a pure maintenance trial, so they have to demonstrate a response to the induction treatment. If you saw if you look at all of the chemo-IO trials, there's not much difference during the induction phase between chemo-IO and IO. It's all in the maintenance, probably an effect in the maintenance, but we don't really know how much education of the tumor microenvironment happens during chemo-IO. But chemo-IO versus chemo in all those trials during the chemo phase, they all overlap each other. So I think, again, as I mentioned, the elegance of the Export-EC trial is that it's taking a hypothesis-generated concept from a previous phase 3 trial with a subgroup and formally addressing it in a phase 3 setting. So if you can convey that, and the rationale for that is based on the biomarker and the drug, then that would be the way I would counsel.
Yeah, I have that trial open, and it takes a lot of counseling, but I start them off on chemo-IO because I don't know if they're going to progress or have a response. So so for that reason, I'll start them on it, and then I discuss with them that yes, there is benefit in the PMMR population, but I think we have more more to gain by potentially getting the selinexor on trial, and patients opt for it.
Yeah, I think the GY026 also,
Yes.
what is, I think, relevant in that design is that it allowed early stage. So that, in my opinion, was a very attractive opportunity. In the advanced stage patients, I agree. I think it was a bit more difficult in the context of the control arm based on the data that emerged. But we were kind of stuck because, as we've seen historically, the trial is designed and activated before we get the data from the other studies, which change the standard of care. But it's a great question.
We, in Europe, have the possibility to add olaparib to durvalumab in the maintenance phase.
Yes.
I didn't hear anything about that. I understand that in the US, you don't have this option, but if you had, would you consider this for any patients, and if yes, for which patients?
God, Dr. Colombo, what a good question. We purposely didn't talk about it. No, I'm just kidding.
Yeah, don't encourage her.
I think that as we think about treatment strategies, and the way I, in my mind, rationalize this, I can only use the data that's available to me. I'm obligated to look and compare the data from the 3 studies to one another, because that's all I have. We don't have a study where I've looked and can assess. If you look at the morphology of the curve for chemo-durva versus chemo alone in DuoE, that curve looks completely different than chemo-dostarlimab and chemo-pembro. I don't know why. That curve separates at 12 months, which is confusing to me because the other curves separate at the start of maintenance, which makes sense because the whole point is, as Rob alluded to, you're doing some immune education, and then you have one cohort that goes onto the placebo, the other onto the checkpoint, and you see a difference and it's preserved. So I don't know if it's the drug combinations, and I don't know what, in my mind, I'm trying to understand the relative contribution. Now, I just heard actually from Dr. Weston earlier today that NCCN notification will list durva plus olaparib in the PMMR.
In the PMMR. I think
PMMR. So I don't know what's going to happen, to your point, now that it's NCCN compendium listed, what will the utilization be? The other part of this that I think is something we're considering, because in the United States, we've lived through the PARP retractions in ovarian cancer, is what is the implication in then subsequent line of therapy? That data, I think, is going to come. I'm excited for Dr. Weston and the DuoE team to continue to report this out. And my hope is that we're going to be able to make a more informed decision, because right now, I struggle a lot about adding or not, personally.
Let me ask you, Nicoletta, since you have access to it, in your DMMR patients, do you think there's any value to give the olaparib on top? Yeah, that's okay. Right.
Yeah, the PMMR is the issue.
Yeah, the PMMR is probably where.
Do you guys?
And I wish we had a better biomarker to help us identify who the HRD test positives are, but. Yeah.
Are you utilizing it?
Yeah.
And I am utilizing it.
Yeah,
Yeah.
P53.
And a P53 mutated NSMP.
Yeah.
Or, sorry, PMMR.
Yeah, tumor.
And then I send foundation, and so I get HRD-Sig, and if they're HRD-Sig, I will add it.
But that went against everything I presented, Bob. No, I'm
Yeah,
just kidding.
thanks. Yeah. Exactly. The subgroup that'll make decisions on it.
All right. Thank you, guys. What a great session.
Yeah,
We are incredibly grateful. Thank you to my presenters and my colleagues. This session will be available as part of the IGCS On-Demand program following the meeting. And again, thank you to GSK, who's the sponsor and supported this symposium. And we hope you guys have a wonderful afternoon. Thank you.